And we're live in 5,
4, 3, 2,
1.
All right, good morning, everybody. I'm Jens Chapman, and this is the Seattle Science Foundation, SSF, and today is November 6th, the day after a momentous election date, and it is a particularly cool occasion to talk about new approaches in terms of spine surgery, and from nowhere less than from the famous Mayo Clinic, Dr. Mohamad Bydon is going to speak to us, and I'm going to introduce him in greater detail later. Dr. Bydon is a neurosurgery professor in the Department of Neurosurgery at the Mayo Clinic, and again, greater details later, but a very accomplished, multidimensional academician and surgeon. Dr. Bydon, are you live with us?
Yes, I can hear you. Hello.
So welcome all of our audience around the world is in terms of spine surgery, and from nowhere less than from the famous Mayo Clinic, Dr. Mohamad Bydon is going to speak to us, and I'm going to introduce him in greater detail later. Dr. Bydon is a neurosurgery professor in the Department of Neurosurgery at the Mayo Clinic, and again, greater details later, but a very accomplished, multidimensional academician and surgeon. Dr. Bydon, are you live with us?
Yes, I can hear you.
Great. Thank you so much for joining us this morning, and we really appreciate you coming, and we are looking forward to your presentation on robotics and spine surgery. And as always, we have 4 cases that 4 of our wonderful fellows have brought up, and we'd like to hear your thoughts and ideas about them. None of them are tricks or curveballs, but it's just a new era for us. We've just now started having 2 different robotic systems, no names here necessarily mentioned, but you can probably guess who they are. And if it's okay with you, I'll just run this band. Dr. Colin Gold from Iowa is going to take the helm first and show us a non-robotic case, but just one that just questions why do we use high-tech in cases. Colin.
All right, so thanks for the introduction. Here's the HPI. This patient is an upper 70s-year-old woman who came to clinic with a chief complaint of left hip pain primarily. This is in the setting of chronic low back pain that has been ongoing for many years. Her new episode has been ongoing for about 2 months. The pain radiates down the outside of her leg and is associated with numbness and tingling in a similar distribution. Of note, the patient had a left breast mass that was biopsied on the same month of presentation and was told that it was not cancerous. Physical exam, patient is essentially completely neurologically intact, no abnormal reflexes, full strength, and normal sensory exam. Initial imaging modality was X-ray. We can see a pretty normal appearing X-ray here of the lumbar spine. And MRI.
Can you go back just one slide, Colin?
You can see a mass in the epidural space at L5, kind of L4, L5, but mostly coming from the L4 vertebral body in the epidural space, causing central canal stenosis.
And how long has this been going on, Colin?
About 2 months. And there was no contrast with this study.
Okay. And a pan-neural axis MRI was obtained, and there was nothing else going on?
Correct.
Okay. So full disclosure, none of the 4 cases today are mine, so I'll have to ask some very naive questions. And do you have a CT?
Yes. Here is CT scan. I included the Hounsfield units at L1 was 110.
So right on the dividing line of osteoporosis.
Yep.
So would you describe this as a, there's not a real bone involvement, right?
Yeah, there's no bone involvement.
It's a soft tissue lesion, but there's a bit of stenosis there?
Maybe a little bit of reactive bone changes right there. You can see in the posterior L4 body.
Agree.
But not much.
So maybe partially lytic with some stippled calcifications, pretty significant. It's a grade 1 degenerative spondylolisthesis, facet joint arthropathy. And did you calculate a SIN score for us?
No, I didn't calculate a SIN score here.
But this would be in principle, outside of like grade 1 degenerative spinal disease, a stable lesion.
Yeah, it would be.
And she has no objective focal neurology, but she has a large epidural mass effect.
Correct.
Okay. And so this is something that we see a lot, Dr. Bydon. And again, thank you for joining us. What are your thoughts again? Is this something where we biopsy again, like 80, 90% canal compromise?
Yeah, I
No
think a
new
biopsy.
structural lesion. Patient can't walk, 2-month history. This is not an easy location to biopsy. What are your thoughts in these cases? We get those all the time nowadays. I mean, it's incredible how much, especially metastatic lesions, have taken over. What are your
Right.
thoughts? Is this a biopsy wait and see case? Or is this something where we as surgeons just have to do something?
Yeah, no, I think you can take, kind of two approaches. One, obviously try to stage and identify a primary.
Also waiting for
Um,
Dr. Pine to get connected. So,
yeah,
Colin,
I, c-
when you
are
go
you
through
not able to
those
hear me?
axial images,
I can hear you.
aside
Can
from
you
the
hear me, Dr.
spine,
Biden?
how
Yeah,
can
it sounds
we
like they can't hear me in the
glean
room.
I
insights on the
know. We're
patient's
just
wellness
working out
by
a
the
little
muscle
technical
mass?
issue here.
So you can look
If
at
you wouldn't
the
mind
cross-section
just being
view of the
patient for just a
muscle and
moment.
how much
Sorry,
fat
just a
replacement
sec.
there is
Sure.
intrafascially here. So you can see this kind of stranding in the muscles, and especially along the spine itself, the multifidus muscles are not really present, mostly fat. I'd say at least half, maybe 50% fat replacement. So that could be a kind of indirect measure of her overall health and general
Cystoponia.
fitness.
There's a shoulder score in the orthopedic world.
Patient for just a
Muscle and
moment.
how much
Sorry,
fat
just a
replacement
sec.
there is
Sure.
intrafascially.
So we have a asynchronous
Kind of stranding in the muscles, and especially along the spine itself, the multifidus muscles
All
are
right, Dr. Biden,
not
maybe
present, mostly
try to
fat
speak now.
replacement, at least half, maybe 50% fat replacement. So that could be an indirect measure of her overall health and general
Cystoponia.
fitness.
There's a shoulder score in the orthopedic world.
Patient for just a
Muscle and
moment.
how much
Sorry,
fat
just a sec.
replacement there is
Sure.
intrafascially.
So we have a asynchronous.
Stranding in the muscles, and especially along the spine itself, the multifidus muscles
All
are
right, Dr. Biden, maybe
present, mostly
try to
fat,
speak now.
half, maybe 50% fat replacement. So that could be.
Are you guys able to hear me?
Yes, we can hear you. We have kind of a weird playback here. So there's a shoulder. I'm not sure whether this is like a recording back with a waves. Try Dr. Biden.
Sure.
So we have a asynchronous with us.
There, better. So what happens when I'm the live screen and the Zoom call?
It does sound like there's an echo, but maybe that's getting resolved.
That is resolved. Good morning again. Now you're live.
Hi, good morning.
And
No,
so we have a simple startup, a warm-up case of something that we see literally every other day nowadays, a neoplastic disease, likely metastatic, and patient can't walk anymore, difficult to reach location, patient has no focal deficits. I don't know, did you see the images, Dr. Biden?
Yeah, I see them now. So obviously, it's obviously helpful to have contrast images. What I see there looks like a T2. And so post contrast images. And then you mentioned, and I fully agree with you, pan neuroaxis imaging. And then obviously staging, and whether you're going to stage with a PET is fine, of course, that's great. Or if you can't get a PET, then a CT chest, abdomen, pelvis with and without contrast. And so now in the setting of an asymptomatic patient, I think you can take your time to stage to better understand the disease. It's not an easy location to biopsy. In the setting of an asymptomatic patient, if you're not quite sure what the primary is, certainly the radiation is getting better and better and continues to improve. You can always also, get repeat images in a few weeks and see what happens to that lesion. Or if there's symptomatology and it's felt that it can't be radiated, then, you're looking at surgery.
There we go. So Colin, tell us your thoughts. Colin is, by the way, a neurosurgical colleague who has joined us from the University of Iowa, so not too far away from you.
Great.
What was the thought process in terms of how you proceeded?
Well, the patient had essentially severe or even critical canal stenosis. So I would think that doing Any kind of medical treatments? Well, I guess first off, the need is to get a diagnosis. So the easiest way to do that is surgery and then treat the neurologic symptoms at the same time. As you mentioned, difficult to biopsy region, but easy surgical approach. So that was the rationale here. Wide decompression, resect the mass completely, get a diagnosis, and then we ended up adding instrumentation as well, given the kind of marginal bone quality and grade 1 spondylolisthesis here.
All right, so excisional biopsy
And what was it?
So the diagnosis was diffuse large B-cell lymphoma. And then the actual surgical procedure was L405, posterolateral fusion with navigation, removal of mass, and allograft bone.
And then what did the patient ultimately end up getting for the lymphoma?
And she's still hospitalized. This took place about a little less than a week ago, so no further treatment at this point.
Yep.
Here's a post-op CT.
So now this is, there are multiple tangents to this. Obviously, there's the oncologic disease aspect. We're talking about robotics today. We're not talking about AI and decision-making help, although I can foresee that in the near future, we'll put this into our spine chat GPT, and spine chat GPT will tell us what to do. But why the screws? Was that the grade 1 degenerative spondy, or?
I believe it's a combination of the spondylolisthesis, wide decompression necessary to get to this lesion, since it was ventral and pretty midline, and kind of even bilateral. Yeah, and then the stealth part was to get the screws having good anterior purchase. You can see how long these screws are.
So again, this is, I think, a very reasonable thing. I know what you think, Dr. Bydon, but
Agree.
Putting hardware into that setting to avoid a further destabilization is fine. How radical do you have to be in resecting such a lesion as you don't know what it is?
It's hard. And a lot of times, when you're not quite sure what it is, it ends up being a lymphoma, which is a highly, radiosensitive lesion. And so with a lymphoma, I don't think you have to be overly aggressive. And so generally with these tumors, I like to know what they are before going in. Obviously, having said that, in this scenario, it's not easy. I think if you're dealing with a schwannoma, a meningioma, an ependymoma, I think you want to try to get all of it, and your best shot is that first time that you're in there. A metastatic lesion, in many ways, is a different story, because by the time that things have metastasized to the spine, they're elsewhere, and oftentimes you will be dealing with recurrences, you will be dealing with return of the pathology, and so I think a primary lesion where you can ideally get a cure, I think that's very reasonable. And I think in a case like this, I think getting a biopsy, understanding the pathology, and then your decompression has done a lot for the patient already. So, and then you've stabilized, and then you can get them onto their systemic treatment.
So now a technical question. You used navigation. This is a very basic case. How did the navigation help you?
I didn't do the surgery, but I was told that the rationale was to get the screws maximum size, so diameter, length, and getting some anterior cortex purchase.
For the without mentioning names of manufacturers, is there a need for a special CT, like a 1 millimeter cut CT, to help with that navigation? Is it one of those that merges fluoro data with standard 2 millimeter spherical helical type CTs?
So this was intraoperative CT, so the patient just had standard CT pre-op, and then, I guess you could argue extra radiation of intraoperative CT, but otherwise normal radiation dose from the pre-op planning CT.
Dr. Bydon, you live and work in one of the most prestigious academic institutions in the country, if not the world. And I don't know how it is for you, but do we have to have navigation nowadays to do relatively straightforward cases? Where do you fall on the line of using tech for even routine cases if you want to do instrumentation?
Yeah, no, and thank you so much for your kind words. It's a pleasure to be with you. I've actually been to the Seattle Science Foundation courses in the past, and I trained at Johns Hopkins. I remember flying out to Seattle to your courses, and always learned a great deal from the great Seattle Science Foundation and the great Swedish Institute that you have there. So I would say, at Hopkins, I participated in a publication looking at freehand pedicle screws. And at the time, we had Ziego Koslin and six of his either current fellows or former fellows who went on to become faculty. And all of them were doing freehand screws, every single person. And so we never thought, I mean, if it was a very complicated case, we would do it in a room that had an intra-op CT, and you would do the screws freehand and then get the intra-op CT afterwards. And so, and that was for rare cases. So it's a little bit interesting now, we see the spread of navigation, the adaptability has gone way up. I think for a case like this, you don't necessarily need the navigation. I think it's fine to have it. I think if you were particularly concerned about the bone quality, and that's a reasonable consideration. So I don't think it's necessary, but certainly the adaptability has increased dramatically.
Great. So this is one of those things that I'm just very curious about. Who's next? You'll go next? Okay. Dr. Minnesota is going to take this one. Thank you, Dr. Gold, for this initiation case. This is one of those things that I'm very curious about because we're having this enabling technology, as it's being titulated, more and more put upon our daily practice, and we have more and more fellows who don't know how to do basic instrumentation, and they somehow still have to, or are expected to know how to troubleshoot if the technologies that we have are not quite working. We'll switch to the next case, as we have 4 cases to go through before your presentation. Dr. Minnesali is with us from Rothman from Philadelphia, and he has another case with another slant. So thanks for preparing this case, Nick.
Yes, of course, thank you. So I have no disclosures for this talk. We have a upper 60s-year-old male who had symptomatic pseudoarthrosis after a prior fusion in the setting of Past disease or spinal tuberculosis. He is an end-stage renal player on hemodialysis, not a smoker, diabetic, and does have obstructive sleep apnea. He has a significant past surgical history with regards to what we did here. Initially presented to an outside hospital with what was thought to be a vertebral compression fracture of February of 2022. After failing about 4 to 6 weeks of conservative management of that, an outside surgeon performed a kyphoplasty at that level, and unfortunately within the next month or so was found to be infected and underwent laminectomy and evacuation of the epidural abscess at that time. Presented to our institution several months later after failing medical therapy for the treatment of the TB, which they found in April. And then at our institution underwent an L1-2 revision LAMI corpectomy and a T10 to L5 posterior instrumented fusion with a staged L1-2 corpectomy, lateral corpectomy. So the patient now presents approximately 2 years later with symptomatic pseudoarthrosis. So on exam at this point in the office, bilateral symmetric lower extremity, mild weakness, no hyperreflexia, really just back pain. So this is just that recap. This is the initial presenting outside films, which the kyphoplasty was performed about a month later. And then after revision or after the washout and finding that the patient had spinal TB, he presented in July of 22 with these films. So significant destruction at L1-2 with an epidural abscess component. And at that time is when he underwent the surgery previously described. And this was our follow-up imaging, which looked pretty good with good alignment. appropriately placed hardware, no issues on the initial upright films in follow-up. And then fast forward to about 2 years later, which was more recently, he developed that low back pain with activity and was found to have pseudoarthrosis in the lumbar spine. So you can see significant haloing around the L5 pedicle screws bilaterally, as well as some around L4. And there we go. This is the L5 level, significant haloing bilaterally.
Nick, let me interrupt you. So during the index procedure, was it known that this patient had Pott's disease, spinal tuberculosis?
No, the very index kyphoplasty was thought to be for vertebral compression fracture, and he came back with infection, which then was found, and this is all at the outside hospital.
So, but it was known by the time that this instrumentation was performed that he had
This
spinal
instrumentation
TB.
was performed after failing medical therapy of the Pott's disease, yes,
Got it.
correct.
I just wanted to reconfirm that. I've actually had the very same case scenario more than once now where kyphoplasty performed, the patient had spinal TB. Dr. Bydon, do you in Minnesota have Pott's disease patients?
Some, not many, a lot more in Baltimore. And so obviously it's not a common condition, but they're difficult to treat. And what you're seeing here is the challenge of, treating these patients.
So yeah, so these are obviously, there are multiple tangents, including public health concerns, disease containment in the hospital. We could go into multiple different rabbit holes on this.
Negative pressure.
Yeah, exactly. I mean, so a long construct was done here. Dr. Bydon, having worked with the wonderful Ziago Kazan, who I'm a strong fan of also, you're no stranger to long instrumentations, right? So when you did these long instrumentations, were there any special things that you do? Most of them were oncologic, obviously, to try to ensure fusion, to try to ensure long-term construct survival?
Yeah, it's hard. I think they did a very good surgery. I mean, you look at the first couple of operations that this patient had, but this is the third one that you're showing. And I think they did a good definitive, surgery for the time that they did it. And so it appears to me that they did everything properly. They did the anterior, they did the posterior, they approached it, they addressed the infection, which likely occurred from the kyphoplasty, which is really what was getting, which is, what would be really troubling in that scenario. So they addressed that very nicely. And now you're left with a pseudoarthrosis. And so now obviously you have to go longer, right? You may have to go to pelvis. But on top of that, what we found when we remove hardware, particularly from a pseudo level, we often send it for microbiology and not like for the 3-day stuff, but for the 3-4 week stuff, specifically to look for P. acnes, C. acnes. And we often find that it comes back positive. They may not be flagrantly infected. In fact, it might look perfectly clean when you're in there. But when you see it, then you have to treat it. And so these low-lying indolent infections can be a setup, in addition, obviously, poor bone quality, but can be a setup for, the exact kind of scenario that you're seeing here with pseudoarthrosis and screws loosening.
So you said to the pelvis, without getting into the weeds here, I assume you'd go to the pelvis and probably enhance the metal construct also. Are you a proponent of quad rods? I think Zia was one of the very first people who started doing quadruple rods for high destabilizing.
Chordomas. Yeah, right. No, absolutely. He does those a lot for chordomas. I think if that needs to be done, I think then it does. Obviously, that's one option, but I think definitely extending the fusion, whether you do it within the same rod system or add 4 rods so that, there's less strain on any single rod system.
All right, so this is a reconstructive problem. Now, there's no ongoing disease that we know of, correct?
Correct, that we know of, yeah.
One thing that I'm always particularly keen on is identifying the patient's nutritional status. So do you have an albumin level at least as a basic screen?
I apologize, there may have been, but I didn't check, and I should have.
So tell us how you proceeded. Again, Dr. Bydon, I don't know anything about any of the cases today, so I'm navigating through that without a robot or. Go for it.
So we extended down with the revision fusion T10 to pelvis with bicortical S1 screws and then bilateral stacked S2AI screws. We also revised and upsized the bilateral L5 screws, and there was quite a bit of haloing there. The preoperative measurements were around 12 millimeters, which makes it difficult to get appropriate purchase in that L5. So what we did was placed cortical cancellous allograft chips down the pedicle, and then placed the largest screw that was safe to do. And then again, went to pelvis with stacked S2AI screws. And so we did use navigation for this, which I did find was helpful. I came from an institution that did not use this, navigation or robotics. And I felt like it allowed us to place the largest screw in an appropriate corridor that was safe, as well as the pelvis screws. And we do them, again, without very frequently, and I'm comfortable doing both, but I did find that it was helpful in this case.
So at L5, you put in a 9.5 or a 10.5, or what
10.5.
size screw? A 10.5. That's probably the biggest you could get.
Yes. Let me see if I can get to the.
But even that's not really going to be big enough. I mean, you could have chosen to leave that out. I can see why you wanted the extra purchase. But yeah, the haloing was so dramatic there.
Mm-hmm.
So just as a technical pointer, actually one of my former fellows in my UW days wrote that up, Hossein Al-Gaddafi, and he showed something that we did where we splintered fibula allograft into kind of shards and put like 3 or 4 in. We would tap up, and you can actually put like a 5.5, 6.5 screw in there. It's a carpentry trick.
Yeah,
so
that's nice.
That's a way better pullout, actually. It's actually impressive pullout, as long as you don't have any foraminal compromise, which I couldn't tell here. And I agree, actually, with Dr. Bydon. I'm not sure I would have bothered about L5 if it's that devastated. Now, Dr. Bydon, in the cranium, the neurosurgical community has really used navigation to great benefit for patients for 2 decades, 3 decades now. I don't even know how long it was, 2 decades at least, because the static osseous structure provides helpful references. In the pelvis, this is one area where sophisticated screw placement really benefits from that. What are your thoughts in terms of using navigation to have optimal pelvic purchase, which was cardinal for this patient here?
It's helpful. It's definitely helpful for pelvic screws. And, when Cal Kabesh described those, I was at Hopkins, and we got to learn those from him. And obviously, he's a master at those. But the freehand methodology of placing them, like any methodology, is accurate, but not 100% accurate. And in a case like this, where you really want this to be the last time that you're down there, ideally, although that's not how these work out, then I think it's very helpful.
So that's a really good point. Did you use quadruple rods?
We did not, single.
Now, that's something where I would differ. If you can't get an osseous union, which is obviously the first preference, I would go for a metal union. And this is an ideal case for that, in fact. Going back to Dr. Gokazan's absolutely beautiful illustrations in Journal of Neurosurgery Spine, with Ian's beautiful graphics, I would have done quad rods. Was that a discussion point or not?
We did not discuss it.
All right. So thank you for that.
I would agree with you. I think particularly with L5 so compromised, this would be a great case for that.
Yeah. So, and the cage was left in place.
Correct, yes.
Good. No, thank you. And now for something different. So we've actually started using robots. And Dr. Bydon, you're obviously an expert, but you're also a very noteworthy authority in this regard. I will show you the first 2 cases, and I did not do this. One of my partners was online. Amir Abdul-Jabbar is live, and he is obviously going to comment. There's this thing called learning curve. So we just started using robots. We have actually 2 different manufacturers. So we had no robots until now, and now we have 2 different manufacturers and 3 different robots floating around. So you're witnessing almost live our first experiences. This is Cameron Hoxett. He's from the DFW area and trained there, and it's great to have him here also.
All right, so yeah, this is actually the first robot case I participated in vivo, so I was happy to be a part of it and to present it today, this morning. This is a 61-year-old female, presents with worsening back pain and unable to stand up straight or ambulate. You can see her sagittal CT scan there on the right. She had an atraumatic evolving pain, no inciting injury or event. That started 3 months ago. She was a previous independent ambulator with no assistance and really no back pain troubles up until that point. She did have a significant past medical history of breast cancer that was last told that she was in remission for many years ago, but she did stop following up with her doctor for regular visits and observational visits. She's chronic kidney disease, liver cirrhosis, type 2 diabetes, as well as high blood pressure. Social history is relevant for chronic alcoholism. She says that she has anywhere from about 10 to 20 wine coolers a day, is a pack per day smoker. She does deny any IV drug abuse. On physical exam, she had no long track signs. She was functionally intact with isolated muscle movements, but really just had debilitating back pain to the point where, as mentioned before, she was basically in a crouched down hunch position at all times, could not really straighten her back out or mobilize due to the pain. Her SIN score, if you wanted to calculate it, presume this was potential breast carcinoma that was metastatic, was 13, so instability and operative management recommended, and then a site score, spinal infection treatment evaluation score, if there was more concern for spondylolisthesis destruction, was a 6, which is basically severe spinal infection with high probability for instability or neural element impingement with stabilization surgery recommended as well. This is our CT scan. And you can basically see osteolytic destruction of the T11 and T12 vertebrae with some kyphotic collapse through those segments. And then she does have additionally a degenerative scoliotic double curve throughout her spine as well that you can see there. You can also see on the axial scan that she has some attritic pedicles there and is also a rotational component to her spine as well.
So here we have, again, a mixture of what we saw before. We had an oncologic case, we had a infection case. Here we have an added complication now with a somewhat of a deformity, poor bone stock, and then a destructive lesion. Dr. Bydon, there's this infamous word called learning curve, which when we apply new technologies comes into play. How would you view that? Are the processes surrounding robotic surgery well enough implemented that we can minimize the learning curve, which is a euphemism in a way for complications? Where are we in this gestalt? Is this a good case? And if you had this new technology and would advise a colleague in an institution that just got this to use this on that or not?
Yeah, so that's probably not the case I would start with. I started the robotic program here at our institution in 2018. And, robotics is still new today, and imagine what it was 7 years ago. So certainly the technology has gotten better and improved. I think all the systems have. But having said that, would that case be the first case that I would do? Probably not. Although it just depends on your threshold for pain. Because it's not just you, it's the whole team, it's the OR, it's everybody getting used to it. And that's a case obviously surgical. Obviously, you're going to have to go several levels above and below those 2 fractures. You're probably going to have to treat. That's a patient that I would have see an endocrinologist for treatment with either Timlos or Forteo or Evenity preoperatively, just to make what happened to the last patient less likely, so that your screw pullout's less likely. But having said that, if you're willing to go through it, certainly once you have a very mature practice in robotics, you've done a lot of it, your team's used to it, then yeah, I think that's a great case to do. And not to say that it didn't go well, it could have gone swimmingly. But whenever you have a new technology, there's going to be a pain factor.
Here's a sagittal CT scan, and just the calculated Hounsfield units there were 80, so significant for osteoporosis, which we could already just tell from eyeball tests there. And then you can also see at L2 that she has a chronic compression fracture below the planned levels of.
And with that many fractures, it's osteoporosis. As long as there's no cancer, which there's no history of cancer here. So in fact, even if there's a normal bone density, most any insurance company will now approve, some of the resorptive drugs that are out there now, just based on number of fractures alone, even with a normal bone density. In this case, obviously you have the Hounsfield, but even with a normal bone density. So.
Yeah.
So this is near and dear to my heart. Dr. Bydon, you, again, have an access and an immersed in one of the major medical systems in our country. Just on the tangent of osteoporosis, have you succeeded in a program development for osteoporosis where we're not reactive to osteoporosis, but use, let's say, incidental readings by radiologists to kind of have a screening tool that's opportunistic and then creates a far more prophylactic management? Let's say a patient gets a chest CT or an abdominal CT for cholecystitis, and Hounsfield units are routinely deployed, or a patient goes to an ER and has some x-rays taken, and using simple current technology, not even a DEXA scan, patients are then put into an osteoporosis clinic. Instead of having a reactive scenario like here, where there's just a dissolution of bone at multiple levels, and we then do some pretty dramatic, high-tech, expensive medicine. Where are you with Mayo and having such a proactive population system?
Yeah, I wish that we had more of the preventative care approach. I think we're in the same boat that you're in terms of reactivity, particularly as surgeons, because we're seeing these patients kind of late in the game of their disease. We do have an active bone endocrinology clinic. I mean, we have 6 bone endocrinologists here in this hospital who are dedicated to osteoporosis and who are dedicated to, frankly, a lot of what they do is CR patients to get them on resorptive medicines prior to surgery. And that way, we don't go through the back and forth with the insurance company. They help us with that. It's a major issue. And I can tell you, operating on these patients when they've been on one of those medications, and much like robotics, there's 6 robotic systems. Honestly, they all offer different advantages. I don't think it matters which one you use. There's 3 different drugs now. I would go off of price and convenience. Some of them are IV, you got to be at the hospital. Some of them are like a procedure. So, but operating on one of these cases when they've had even 3 to 4 months of this treatment versus when they haven't is night and day. It's night and day. It's a pleasant case to a very unpleasant case. And having them, obviously be a part of our practice is a big part of that.
So you can see on her T2 MRI there, changes consistent with spondylitic destruction and discitis. Her rest of her neural axis was negative for skip lesions or spondylodiscitis. She did have a slightly elevated white count. CRP was elevated at 53, USR was 114, also kind of confirming that clinical picture of spondylodiscitis.
Great. So robot was used.
Robot was used, and we use the scan and plan kind of method. There's kind of 2 methods you can go about for robot planning: an outpatient CT scan that has to be 1 millimeter cuts, which you can pre-op plan and use special technology depending on the system to plan your screws, screw height, cage lordosis or cage height, all of those nice things. We did the scan and plan, so you can do an intraop OR spin and AP lateral mergers with a C-arm as necessary. And then this was kind of our workflow for this case. We did plan to use kyphoplasties at the UIV +1 and upper instrumented levels, as well as the corpectomy decompression and cage placement.
So if you just roughly look at these timelines, these are the actual times that you recorded?
Yeah, these are about the times.
Dr. Bydon, are these kind of times that you can do much faster with now? What are your thoughts as you look at these recordings that Dr. Hawks had put together?
Yeah, I'm a big fan of the robot for minimally invasive cases, and that's that's where I lean on it a lot. This week alone, I have 3 cases with the robot, all minimally invasive. Now, for the open cases, robot versus navigation, there's different advantages. The navigation is more forgiving to me in an open case, and so in an open case, the robot often puts you in a position where you then have to go, even if you want to make a minor adjustment, you're walking back to the computer, out of the screen, into the planning environment, replanning the case, back to the patient's bedside, arm adjusts, instruments back in. Did that do what I wanted? Versus nav, where you just boop, done. So in an MIS case, I don't need to do that because there is no opening, right? You make little stab incisions, you're done. It's so fast. It's really painless for me. And at this point, I want to complete the case, as efficiently as possible, as safely as possible, as effectively as possible. But efficiency is a big deal. And so I find a major loss of efficiency in the robot with an open case. Not to say that I haven't used it. I've done it, this year alone, probably 60 times. But increasingly, there's a lot of open cases where I'm saying, no, I'd rather use navigation or a different technique other than robotic because I'm not seeing the value add. And I don't see the flexibility, the nimbleness, at least with the current systems as they exist. And so having said that, these times are all going to get faster as you keep doing this. I have no doubt that there was a fiddle flow. And did it put you off to the side of the incisions, and did you have to extend the incision, and and did you have to pull the muscle back, and now you're pulling the whole robot back, right? So now you're pulling on the muscle, and now all of a sudden it's different. Now where the robot's leading you to be is different from where you'd planned. So all those, the visions are coming in my head as I see these numbers up on the screen. And if they didn't happen in this case, as you do enough of it, you'll see it. So
Yeah, and we definitely did have, being an open case, as you mentioned, some fiddle flow at the most proximal and distal aspects of the incision, where the robot was wanting you to place your screw and your trajectory outside of the incision. And so you would have to extend and would have to retract muscle, move the robot out of the way, replan, like you were mentioning. So there was definitely some fiddle factor there.
which in a navigated case would not happen because you just move your hand, and which in an MIS case robotic wouldn't be an issue because it doesn't matter. You're making stab incisions.
So one other question was radiology. So the untold other thing is that you need high quality imaging beforehand to have actually truly fiduciarily relevant imaging data. So this patient needs a 1 millimeter cut, right?
Correct.
How does this work now? Did this patient have to be rescanned to have that high density information, or?
Traditionally, they're 2 millimeter CT scans when they're obtained up to this point, and so a special order would have to be placed for a higher concentration dose of radiation to obtain a 1 millimeter CT scan to be compatible with the robotic system. That's correct.
Great. Okay, so let's move forward. So we can.
Intra-op, we did still use fluoro. We were still wearing lead. This being our first robotic case, we wanted to really confirm everything, and the corpectomy cage was placed with fluoro. These are intraoperative scans of the kyphoplasties, as well as corpectomy cage and rod construct.
All right.
This is our post-op CT scan. Overall, we were pleased with the accuracy of the hardware placement and screw placement. no cement leakage on the kyphoplasties as well. And so we had very accurate placement of the hardware as depicted.
So is Dr. Abdul-Jabbar alive? Amir, can you hear us? Just as the attending in question, how did this help you? What prompted you to use it? Where were your frustrations beyond what Cameron already mentioned?
Hey, can you hear me okay?
Yes, hear and see, yes.
So yeah, I thought, this was my second case. So when you talk about the fiddle factor and pain, it's kind of something that you have to go into a new technology expecting. I didn't think it was overly frustrating. And we did kind of expect with the open case, the first one I did was a percutaneous case, and there are very different workflows. So, this was, again, something that definitely took me extra time, but you come into it expecting that when you have a new technology, and I didn't think it was overly challenging. I didn't feel like I was frustrated to the point where, you have a threshold where you just bail on the technology and move back to traditional techniques, which, I think you have to be able to, do at the right point when, possibly you're going to be, putting the patient at undue risk. And I think that's something that I will continue to work on. Obviously, having the robotics available, my first exposures, this is something that's very new. And every case is a learning case. But, with the small pedicles, these were 5.5 screws going in kind of 3 to 5 to 4 millimeter pedicles. We were able to get, very good accuracy there. And, again, that's a small part of this case. But I did think it was helpful on that front.
Well, you did a great job, Dr. Amir. You have a beautiful result and nice work.
I appreciate that coming from an expert. So thank you for being with us.
My pleasure.
Yeah, it looks really nice, actually. I'm gonna have to say that's cool, and that's not a straightforward case. That looks really well executed.
I think one of the other things is, we do want to, start with some of the simpler cases. And unfortunately, we don't have a ton of simple cases in our practice. So, I really felt like if I was going to be able to use this, obviously my first case was percutaneous and very different workflow, but, want to be able to see if this works in that setting. And I did feel like it was, fortunately, went relatively smoothly.
Good.
Excellent. Last but certainly not least, Dr. Mark Kramer, University of Wisconsin, neurosurgical colleague, Dr. Bydon. So again, from your neighborhood. And he's presenting another case of Dr. Amir Abdul-Jabbar's. So
Excellent.
Go for it.
This is our index robotic case, actually. So this is an 80-year-old gentleman presented with back and leg pain. He had approximately 1 year of kind of progressive pain, specifically with walking, and he had progressive mobility issues. His past surgical and medical history pretty benign. I previously worked in construction, so a lot of heavy lifting on his back, and not a current smoker. So you can see from exam reported here, about 6 foot tall, 80 kilograms, and full strength in his lower limbs. No other concerning findings on his exam. So here's his initial x-rays that were obtained by his outpatient primary care team. And this showed pretty significant spondylolisthesis, still low grade, grade 2 at 5S1, and then a grade 1 spondylolisthesis at 4.5. And you can see there's some mobility on flexion extension, specifically at 5.1. If you measure his lumbar lordosis and his PI, he's got a mismatch of about 10 degrees or so. So looking at his MRI, you can see pretty high-grade stenosis at both 4.5 and at 5.1. So summary, 80-year-old gentleman. He's got a combination of neurogenic claudication symptoms, and he's got radicular pain, which fit with both an L5 and S1 pattern. He's got a grade 1 spondy at 4.5 and a grade 2 at 5S1. I guess, what are your thoughts on approach for this? Obviously, it's and I don't show the images here, but it's he's got bilateral pars fractures, which you can actually see on the MRI. Should we do a decompression at 4.5 alone and then fuse at 5.1, or fuse all these levels? Should we use a robot?
So oh, sorry, go ahead.
Yeah, so 80-year-old guy, this is unusual for an isthmic spondy presentation right there, caveat, stenosis above. Okay, so I didn't mean to cut you off, Dr. Bydon.
Yeah, no, I think this is a very sorry, I'm getting paged. But let me just put that. Sorry, they come through the phone now. But no, I think this is a very reasonable case for a robotic approach. And I would probably fuse both of the levels. I think certainly if you wanted to do one level fusion and then one level LAMI, I think that's fine. But we all know how that's going to go. So I think it's reasonable to fuse both levels if you wanted to. Either approach is fine. There's different risks and benefits to both. And no, I find that a great case for robotic.
All right, tell us what you did so we stay in our timeline.
Absolutely. So we ended up doing a ALIF, both 5S1 and 4.5. This was challenging, and you could have guessed that from some of the preoperative imaging, because the angle at 5S1 was definitely challenging to get into from the front. So we did have to kind of nip off a little bit of the inferior end plate of 5 in order to get our inner body in at 5S1. But you can see from these x-rays, we actually got a very nice alignment, and I'll kind of scroll through the CT to kind of give you a better sense of that. So we had a really nice reduction of his spondylolisthesis, and you can see the foramen are nicely patent at both 5.1 and 4.5. Nice big titanium cages. We used a combination of some bone morphogenic protein and some allograft in both those cages as well. Once those were done, we actually flipped the patient posteriorly and into the prone position, and we used the robot to place screws at 4, 5, S1, and also we placed S2 AI screws. And those went extremely smoothly. The challenge here is that the pelvic screws do not have a great percutaneous option, so those screws were placed, and we had to put towers on in order to kind of thread our rods in from the top down. So that they had an additional small amount of fiddle factor, but overall went very smoothly.
So reduction is one of those big things. Reduction of the spondy in an 80-year-old, when arguably maybe the 4-5 stenosis might be the clinically more relevant thing. Fusing is a very reasonable and probably necessary option, or not option, but clinical adjuvant. Thoughts on what was done, Dr. Bydon?
Very reasonable, good surgery, nice reduction. So nice work.
So Amir, this is the quote straightforward case to start with. How was that for you? What were some learning points that you gathered from that?
So, for me, one of the things that I think is a little bit of a leap in robotics is, we are told that we can use a, preoperative CT that will register and know where the new position of the bone is after placement of an interbody cage. And so again, I'm not quite at that point where I feel as confident with the system. I know a lot of people who are very familiar with the system that are, but for this one, we did an post-ALIF intraoperative CT and used that just to give me a little bit more confidence that things were where I was going to expect them to be. I've used this technique. It's kind of a mini open to get the S2 AI screws in without having to do a lot of damage to the skin, and a midline incision, and then kind of, as opposed to being percutaneous, it's more perfascial. So just one midline incision, and I think just cosmetically, patients like that a little bit better. So this is a technique I've used before. The only difference was using the navigation/robotic system. And for that part, it did go very well. And I think that the, post-op CT, accuracy is kind of the main thing, that things are where you're going to expect them to be.
So, Dr. Bydon, this is a big point for me. I would characterize myself as a revision surgeon, a reluctant revision surgeon, that is. I get to revise a lot of percutaneous cases, and what Dr. Abdul-Jabbar brings up is very relevant to me. These pelvic screws I see usually well placed with image guidance help. Almost universally, if they're done percutaneously, are outside the fascia and sit somewhere under the skin or in the subcutaneous fat. Any tips and tricks, any thoughts on how to kind of put these screws properly so that they're subfascial in a meaningfully soft tissue protected environment?
Yeah, I find that those particular screws, the pelvic screws, I do find those, better to be done in an open manner, just for that very reason. The fascia there is so close to the bone. You don't have the same, flexibility that you do elsewhere in the lumbar spine. And a lot of times you are fighting it or you're not below it. And so I would agree with you. I think having said that, if you're gonna do it, making sure, they recommend certain fascial cuts when you're using the robot, making sure that you go beyond those recommended just to make sure that you get it nicely opened up and get that screw nicely in there. So I think those are just things that you have to be aware of as you're placing the screw.
And Dr. Bydon, one final question before we go to your much anticipated talk. Mark, go through the parasagials. With these kind of very elegantly done anterior surgeries, I think Amir did a beautiful job there. Do we still have to go and do a posterior decompression? And what about these bone spikes? Like, oh yes, go back to the frame and go back, stop there. So there's a pretty substantial bone spike. In my lifetime of having done several hundred of these spondies, this little, I call it devil's hook that sticks in the front of the L5 root, in presence of a reduction, whether it's anterior or posterior, yes, that's been a problem. That's in my subjective, non-published, observational perspective has been a problem correlating with L5 radiculopathies. Do we still need to do decompressions when we do a nice anterior indirect reduction? And what about these pesky bone spikes? Do they play a role or not?
Yeah, so I think indirect decompression can be very successful. If you were to get a post-op MRI, my guess is that the central stenosis will be resolved. Largely, the foraminal stenosis will be resolved. However, exactly as we're discussing right now, you see those spikes, you can see it right there. It can cause symptoms for a patient. It's kind of variable. For some patients, that extra lift, and they feel better, and they say, "Oh, the numbness is gone, the paresthesias are gone." But for others, they will continue to complain, and that's a very difficult area. And so I think you're right. I think that's a challenging area. Even if you were to do that open, it'd be challenging to address that spike right there.
Mark, any learning points for you? You used a robotic system at the University of Wisconsin in your neurosurgery department. How was this experience for you as a upcoming young, brilliant surgeon who will do a lot of good?
I was actually, there's a bunch of robotic systems, without mentioning names, we used some robotics back at my home institution, and I felt like by the end, we kind of ended up using more as a coat hanger than anything else, unfortunately. We most often ended up doing these cases open, and similar to Dr. Bydon's comments about doing robotic surgery with an open exposure, there's a lot of, I think, issues with that. We definitely had some misplaced screws and some complications. I felt like it didn't really speed us up at all, actually. Yeah, I think if you're doing MIS and it's specifically transfascial percutaneous instrumentation, I think that robotics can actually play a very nice role in your practice.
So great. So with that, we'll conclude the case demonstrations. We thank our 4 fellows for their talks, and I'll give an intro. Thank you, Mark, Colin, Nick, and Cam. Great pleasure and big excitement to introduce our guest speaker today. Dr. Mohamad Bydon is a neurosurgeon and professor of neurological surgery at the Mayo Clinic in Rochester, Minnesota. And he also holds a title of Professor of Health Services and Research and is affiliated with the Department of Orthopedic Surgery. And he is the Charles B. and Ann L. Johnson Professor of Neurosurgery. He earned his BA at Dartmouth and then went to Yale for his medical school. And he trained at Johns Hopkins, as he told us earlier, and he crossed paths with some of the great friends and icons in our field. And he's become an icon in his own right. He has done a spine fellowship, so we love these multi-talented and really focally dedicated colleagues very much. And he's also the principal investigator in the Mayo Clinic Neuroinformatics Laboratory. He has obviously been a stalwart and early adopter of a technology that we're just now stumbling into as middle or late middle adopters. And we discussed some cases, and we could see his wisdom already in his sage comments. We're very much looking forward to a realistic reappraisal of robotics and spine surgery by Dr. Bydon. Thank you so much for sharing your time and expertise with us this morning.
Thanks very much, Dr. Chapman, and really appreciate the invite. And it's a pleasure to be with you. As I mentioned earlier, I still remember very fondly coming out to the Seattle Science Foundation, attending a course that you guys had, and you have just a wonderful group and a great reputation. I'll talk to you a little bit about robotics here. And let me just... Let me see if I can share my screen successfully. Okay, share screen.
Okay, we see you. If you go into presenter mode, we are good.
I'm just going to swap.
Here we
Can
are.
you see it?
Yes.
Okay, great. So, it's a pleasure to be with all of you. I have a longer version of this talk that I won't give you today in the interest of time, but I go through other MIS, minimally invasive types of approaches. And I will say, and I've learned this, the hard way in my career, these are tools. These are all tools. And, I've learned with minimally invasive that sometimes if you force it, it ends up being a little more painful than what you would have done otherwise. So don't forget your training. I always tell our trainees, you have to be a great open surgeon to be a great minimally invasive surgeon. And so you really have to understand both. In fact, a lot of the approaches that I'm going to show you today rely on your feel and on your understanding of what this would be in an open exposure. So obviously there's a lot of different robotic systems that are out there. Advantages, you could have smaller incisions, reduction complications. There's disadvantages, which is cost, learning curve. All of those are things that are out there. There's a number of papers and literature about robotic versus fluoro-guided placement of instrumentation. Here's Han et al., 234 patients, of whom 115 underwent robot-assisted, 115 underwent freehand guided, and the screw placement was assessed using the Gertzbein-Robbins scale, which is a scale that tells you perfect trajectory or, flawed trajectory. And it goes, A, B, C, D. And so you can assess how good your trajectory was. And so a grade A trajectory was observed in 95.3% in the robot group, 86% in the freehand group. Good et al. Looking at complications in minimally invasive robotic guided versus fluoro guided fusions. This was 9 sites looking at 485 patients with a really good 1-year follow-up rate. And the robotic surgery had a lower complication rate and had less fluoroscopy time. And the risk of revision surgery was 11 times higher in the fluoroscopy group, understanding that both are actually low. So the risk of revision surgery is low in open fluoroscopy or robotic. Han et al., this is a minimally invasive robotic versus open fluoro-guided instrumented fusion, 30 patients in each arm. And so 35 levels in the robotic group and 40 levels in the open group. and a significantly shorter duration of fluoroscopy in the robotic group, leading to a mean reduction of 62.5% in radiation exposure. Sturgis et al. Is a pedicle screw revision looking at robot-guided, navigated, and freehand thoracolumbar instrumentation. They looked at 37 studies, reduced postoperative revisions in robot-guided and navigated procedures compared to freehand. So the robot-guided did marginally better than the freehand, but essentially both did better. Did marginally better than the navigated, but essentially both robotic and navigated did better than freehand. And intraoperative screw revisions were comparable, but the postoperative is where it changed. And then if we look at cost, right? So if you can reduce revisions, if you can reduce having to go back to surgery, what's the cost reduction? And so, this is a study that looked at 1,985 elective cases, 557 thoracolumbar screws. And what they found was the improved pedicle screw accuracy due to robotics would have resulted in 9.47 fewer revisions. And that would have given a cost savings of $314,000. That's, of course, to the overall healthcare system, to to the insurers. That's who would benefit from that. So, obviously navigation, this is Lee et al. And navigation here was associated with, meaning adding navigation to the robot. And they looked at two robotic systems, one robot plus navigation, one robot without navigation. And what they found was that the robot without navigation had a lower, the robot with navigation had a lower robot abandonment rate and less fluoroscopy time than the robot without navigation. And this is our experience. This was an early paper that we'd published. The name of the robot itself is less important because I think we've tested all of them. I think all of them fare pretty well and pretty evenly. But I think it just, a lot of times you're getting it through contracts related to instrumentation. And so that's how you're getting your system for the most part. And so in this paper, we did 97 pedicle screws, 8 cortical screws. You can see the MIS versus the open. You can see primary versus revision, the pre-op diagnosis. Radiation exposure, you can see that, you can see exactly what the radiation exposure looked like for these cases. Perioperative outcomes in terms of number of screws revised, time, EBL, length of stay. This is a 53-year-old female with a left L5 radiculopathy, a grade 1 L4-5 spondylolisthesis. And so this is a case where I would do a left-sided L4-5 minimally invasive TLIF with percutaneous L4 and L5 screws. So I'll show you the steps for this case, in my OR. I do the pre-op CT, which exactly as indicated is a thin cut 1 millimeter CT. This is my OR. This is St. Mary's Hospital, OR 708. That's where I was yesterday. That's where I'll be tomorrow. And so I'm consulting today in the clinic. And so this is my room and my OR setup for these particular cases. I start with rigid fixation. This is standard, which is a Shands pin into the mid-third of the sacrum, just lateral to the SI joint. You want to lock it in. And then we do what's known as a 3-defined scan, where you're defining the patient anatomy. You're allowing the robot to calculate depth and trajectory. This is a what's that?
We're live again. Good. We lost your audio for a second.
Oh, you did. Sure. This
Okay.
is a snap. This is a snap shot step registration of the navigated camera. This is a passive planar probe. You put it just to estimate the level of interest. Registration, this is a target extender that gets attached to the robotic arm. Registration, 2D fluoroscopy combined with a pre-op CT. And then finally, the skin incisions. And so this is what the incisions look like. And this to me is where, robotics can really shine in this kind of case. And so I like to insert the K-wire into the disc space, confirm that on fluoroscopy, and then proceed with my screw placement. So there's the left L4 pedicle, and then placement of a drill guide that goes through the cannula. This is insertion of a 3mm drill through the drill guide. The pedicle then is tapped over a pilot hole, in this case a 5-5 tap. Verify the bony integrity. And then I know that, all my screws were placed in a similar fashion. And then I turn towards placement of my sequential dilators to reach an 8mm tube, and then percutaneously do a discectomy, and then place my inner body. And then that's the completion of the surgery. Placement of the rods, final tightening of the screws. I do get a lot of questions around the rod placement percutaneously. Obviously that's the same process in a percutaneous case. I like to go from top to bottom, although if that becomes difficult, particularly in a certain pelvic incidence, then, you're going from bottom to top on those cases. We did publish on this, initiating a robotic program in spinal surgery, looking at 3 sites, looking at our 3, kind of Mayo sites where we did this. And, we published around this, published these images, and published the data from our first 77 cases, and exactly how that panned out. And one thing that you can see is our operative time during this period came down, and our frequency of use came up. And so you can see operative time coming down, frequency coming up, fluoro time came down as well. So all those things, were, boding for a positive result. This is a 63-year-old female, mechanical back pain, that's 7 out of 10. Bilateral radiculopathy, left greater than right, and had failed non-operative measures and 3 injections. And so, that's the case there that you're looking at. Obviously the L3-4 is an issue, and then you can see the L4-5. You'll be able to see the MRI in a moment, and then at the L5 S1, you'll be able to see that as well. And so you can see here central stenosis at L3-4 and L4-5. With foraminal stenosis at L5-S1 and radiculopathies that were consistent with L4-5 and S1. And so in this case, this would be my operative plan. This is my intraoperative imaging. And that's the, end of that case. And so this is the advantage of doing this in a minimally invasive or robotic fashion, is that you can complete this quickly, efficiently, get the patient home. This is a 21-year-old with progressively increasing back pain since he was 13, a 10-month history of lower extremity radicular pain, non-responsive. So you can see here, this is a grade 3 spondylolisthesis, and you can see it's a fairly severe high grade. So this is a case that, previously I would have done with potentially an L4 to pelvis, front and back. More recently, I'm approaching these all minimally invasively, all posteriorly. And I'll show you exactly, how I do that. Here's CT and MRI. And so in this case, I place my K-wires, I place my instrumentation, I place special reduction screws, all the screws that any, robotic system, they're all going to give you some reduction, maybe 10 millimeters, but in this case, 10 millimeters isn't going to cut it. So you really need larger reduction screws that have much more powerful reduction than what, your standard robotic screws are going to deliver. And what I like to do in this case, I like to place 2 drills, one on each side through 8 mm ports, percutaneously do a discectomy, and then reduce over both drills. And you can see as I'm putting them in, you can actually see the reduction occurring in this case. And so you can see there the reduction that we're gaining all from L5S1. There's the pre-op CT. You can see on this right-sided image my 2 drills right in the disc space in a percutaneous manner. And those are the drills that I'm pulling back on. And as I'm pulling back, I'm using these, extra reduction screws to reduce even further from where things would have been. And then finally lock in. And this is what it looks like post-op. So that's the pre-op, that's the post-op. And this, an MIS case like this, you can do it quickly, patients getting out quickly. And so this is a real advantage. And in my practice, this changed things from, what would have been a front back, a forward pelvis to, this kind of surgery. And so that I found to be very advantageous. Robotics will adjust and advance over time. Laminectomies and osteotomies are going to be occurring more and more using robotics. There will be automated rod bending, augmented reality, AI tools and techniques. And so, obviously it's come a long way, robotics in the past many years, and will continue to advance and change. And, more and more people will end up adopting it over time, as we've seen with navigation and with other things. So thank you.
Really nice, thank you. So many questions. We have 5-10 minutes or so for some discussion points. So for our young practitioners, I have 4 great young minds. You got to meet them digitally before. As they're heading out into the wild world of spine, should they present themselves as early adopters to be competitive in the marketplace, or should they be kind of just trusting their skills and having worked with a dinosaur like myself, the Yenzobot, who basically tries to use common sense basic skills to the best possible degree. What's your advice to young surgeons? Is this necessary now in the marketplace to compete effectively?
I don't think it's necessary to complete. Obviously I use it because I find it advantageous, but it's not 100% of my cases, not even close. And so, I would say learn all the tools and have all the tools at your advantage, and then utilize the ones that you think will be most helpful. And one of the mistakes that I would say, especially when you're starting in practice, is forcing a solution onto a problem. And you don't want to do that. And certainly, at a place like Swedish, you've got the breadth of experience where you don't have to do that. You didn't learn one way to do things, I have no doubt. You learn multiple ways to do things. And so what you have to think through is the different tools and when is the opportune moment for me to utilize that tool, much like you would, in a multitude of other industries and ways of thinking about it. And so no, I think people have built great practices out there, and it always comes down to the same thing. It's, delivering good care, and that's how you're going to get it. And this, Jens and Amir and others, but it's your patients who are going to send you more patients, and that's how your practice is going to go. And I have no doubt, coming from where you guys come from, you're going to have, excellent results, and your patients will be sending you more and more, patients to see you. And so I think you'll be in good shape starting out your practices.
That's a really good point. By the way, I print out my final x-rays, and my team gives them to patients, just a simple paper cutout, and it has my name attached to it, so nothing special. And I try to make my x-rays look, within best possible reasons, nice, because I find it's the best business card in the world. And they frequently hang it on their fridge or something like that. They pass it around. Best business card in the world. Couldn't agree more.
That's great. Yeah.
Perspective questions. One systems, one patient perspective. So maybe let's just go from the system first and then go what ultimately matters, the patient perspective. So systems perspective, I'll throw a number out at you. So many years ago, 7 years ago, 5 years ago, when robots first hit the marketplace, our healthcare system, which entails, I think, 52 hospitals or something like that, did an analysis, and they concluded that for the system to benefit from robotic surgery, we needed roughly about 50 de novo cases that have not come to our place in the first place, instrumented spine cases, to benefit from this financially. Is this a number that, without revealing fiduciary things that you signed your life away for, is this roughly a reasonable sounding number to have the significant acquisition and maintenance cost, the latter being that submarine cost that's not insignificant for anybody who listens in our global audience? So how does that factor in? Do you need a certain de novo volume to make this work, or do you benefit enough from avoiding redo cases, things like that?
Yeah, so I think they're saying 50 per year, and I think that makes sense. And remember now, every hospital has to publish its costs. Mayo's done it. I have no doubt Swedish has done it. Every hospital has to. So you take an average NOI of 25K on a spine fusion, 50 cases per year, yeah, that's a winner. And so, because then you're getting, your average 1.2, and that's paying for your robot. But a couple of things have changed. So one, is the cost of the robots often are now built in to the instrumentation contracts that you have. And so that's one option to obtain it at a very low cost, in addition to other, technologies and tools. And then the other aspect is that the margins for hospitals, it's funny kind of how hospitals think about it. The margins are getting eaten away. And so what they want to see, to a hospital, the more levels you fuse, the better from a financial standpoint, up to a point, right? I mean, up to maybe 3 levels. And then once you're going beyond that, that's when the instrumentation costs start racking up. That's when some of the other costs start racking up. That's when the discharge isn't happening so quickly. So then they become worried about that. And so, those are all considerations for the hospitals. Obviously, for you and your practice, treat the pathology, treat the disease, do the best care, and you'll get by just fine. And so that's on the cost side of it. And then what was the other end of that, Jens?
So let's just switch to patient perspective. So one thing is, we alluded to that earlier, radiation. So there's a decreased radiation if everything is done right and well for the surgeons, the practitioners, and the OR. From the patient perspective, we need far more ionizing radiation data prior to surgery to do good planning. So we need 1 millimeter cuts. Frequently, our patients come with whatever other CT technology. They've been radiated already once, and then we need to get our 1 millimeter cuts. And if we spin in the OR, that's not an insignificant radiation burden in addition to that. So is there a net reduction of radiation to patients also with these enabling technologies, surgeon enabling technologies, I should say?
So we find reduction in fluoroscopy to the staff, to the surgeon, to the patient in the OR. But to your point is, what about the pre-op X-ray? And I don't know that anybody's ever looked at that. Certainly if you're going to get a pre-op X-ray anyway, but if you got a pre-op X-ray and now you have to do another one to make sure that it fits with the robotic program that you need, now you're getting CT, now you're getting 2 pre-op CTs. And so, yeah, that could be a lot, but it's a good point and a good question that you raise.
No, for me, this has been, actually, Amir brought that up to us. In our system, we have obviously an Epic, not divulging any great secrets here, healthcare record system. And we had to modify the ordering sequence. So we have a dedicated 1 millimeter CT. The preoperative robotic one was not good enough in terms of the image grid placement. So we found that in our very young program, we actually have to get repeat CTs on these patients. And I've learned that from other centers also. So being very cognizant as to what we might be doing, and maybe also disclosing that there's a higher radiation burden actually for patients. So that's the the point there. The final question is a population health question. I know you're a population health physician also, not just an excellent surgeon. Industry obviously has an interest in us using robots, and unlike the Da Vinci system, which is done for prostate soft tissue resections, these robots are heavily tied to instrumentation use. As I'm getting older, I'm seeing more and more fusions done. I sound like somebody from my early career in the 80s and 90s, where the clamor about us was we're doing too many fusions. This is nothing compared to what I see now. Are we kind of doing more fusions now because of this revolution? Are we doing more unnecessary fusions? I'll be contentious.
Yeah, no, I'm very sympathetic to that question. And it's a great question. If you follow the national trends, lumbar laminectomy has always been the most common procedure in spinal surgery until about 5 years ago, when lumbar fusion overtook lumbar laminectomy and is now, and there's no end in sight. You know, you might have thought, oh, that was just a blip. There's no end in sight. Now it's really divergent. In fact, I've been to meetings where I've heard things like people say, I no longer believe in lumbar laminectomy. And my counter to that would be the following. We're doing surgeries for arthritis, right? For degeneration. So these are conditions of wear and tear. There is no permanent surgery. It's not like if you initially see the patient and eliminate every possible motion segment you can, you've solved all the issues and they'll never need surgery again. So that's the key. And so I do cervical foraminotomies. There are 3 people in our practice that do. The other 2 are much older than I am. I love it. It's a great surgery. Patients are happy. They're out the same day. Doctors love it. I treat maybe 1 doctor a week. Doctors love it. When doctors come in, that's what they're getting right away. I know it. I don't even talk about it. I say, let me guess, you want a foraminotomy. That's what they want. And guess what? I mean, they're not stupid. They know, hey, in 4 years, you might need an ACDF. Fine, I'll get it in 4 years. In 3 years, whatever it is. It's not like if you do an ACDF, that's the final surgery you're ever going to do on that patient. So you might get adjacent segment, and now you're doing 2, or you get a pseudo, or you get, you know, and so there's always something. And so I agree with you. I think it's a concern. And there's a friend of mine who says, and this really sticks in my head. I mean, he's the guy, he's the deformity guy in the part of the country that he's in. Okay. And he said to me something that really sticks with me. This is a deformity person. This is a person who only does fusions. Okay. He said, you know, a T10 to pelvis used to be reserved for a 70-degree curve. Now everybody gets it. Who doesn't have flat back? You know, you have stenosis, you have flat back. You're leaning forward by definition. So I'm very sympathetic on that. I think that happens, and I don't think people do it purposely. I think there's always a reason to do it. But just keep in mind that that it's, you know, you want to address the problem in front of you efficiently, quickly, effectively. But these are not 50-year solutions that you're delivering. None of us. And so just understand the pace and the trajectory of the solutions that are being delivered. With an MIS decompression, you know, even an immobile low-grade spondy, I've done a bunch of those with small MIS decompressions, get them out the same day, particularly if they're sick, if they have bad bone quality, if you don't want to put them through a fusion, you know, those kinds of things. So just, you know, again, I would say, don't force a solution onto the problem. Take the problem and take the many solutions that you've learned in your excellent training and deliver the right solution to that problem.
This is a great point to end on with. I think it's so exciting what you've shown us, and I think I congratulate you on your scientific work and your very rational approach and nice technical execution. But again, a well-performed decompression is and should remain one of the hallmarks and trademarks of our profession that we're proud of and execute really well, rather than focusing too much on reference points and enabling high-tech technologies. Doing a very nice, clean decompression is and helps so many patients. And hearing lecturers speak about, oh, I don't believe in decompressions anymore, that gets my ire going. I sense a great deal of sympathy with you. Dr. Bydon, this was really terrific. Thank you for your time. On behalf of our global audience, also, we thank you so much for time, expertise, and just a wonderful discussion and interaction with you. Much appreciated. Thank you, and till soon, I hope.
Thank you. Talk to you soon.